Hello, I am Eli Adashi, Professor of Medical Science at Brown University and host of Medscape One-on One. Joining me today is Dr. John Wennberg, the Peggy Y. Thompson Professor in Evaluative Clinical Sciences at Dartmouth Medical School. A widely revered health policy expert, Dr. Wennberg is the founder and director emeritus of the Dartmouth Institute for Health Policy and Clinical Practice. Welcome.
Thank you.
To One-on-One.
Thank you.
Delighted to have you. Back in 1973, you and Dr. Gittleson published a seminal paper in Science wherein you laid out, perhaps for the first time, the whole notion of unwarranted variability across our nation in terms of costs, utilization, perhaps quality. What was it that led you back in 1973, or probably prior to that, to delve into this arena?
Well, it's a kind of a long story, but I can make it short. Basically, when I finished my residency program at Johns Hopkins, I also took a MPH program, so I was trained in epidemiology as well as clinical medicine. And I'd also spent some time at the Homewood campus at Johns Hopkins looking at, in the Department of Sociology, basically trying to figure out how systems work as well as how individual people are motivated in their life's work. What really happened was I got a job in Vermont as director of a planning program. It was called the Regional Medical Program, or RMP. And the RMPs were the last time the NIH ever got involved in trying to fix healthcare. But basically, they gave very large block grants to medical schools, mostly, under the assumption that they could regionalize health services for major conditions, heart disease, cancer, and stroke. And it was a pretty good amount of money. I think it was over $350,000 that the University of Vermont received. And they, in their wisdom, decided that I would be the director of the program. And that's how, at least, I got the leverage and the opportunity to begin to use routine databases to analyze what was going on in clinical practice, or put it this way, more definitely, what was going on in the regional healthcare system. And that's when Alan Gittleson and I basically put our heads together and came up with this idea of small area analysis. It was ideal to do so in Vermont because Vermont is divided up into some 15 different communities, each with their own hospital, and people tended to use the services locally. So since we were interested in regionalization, the whole idea was, well, let's find out what's going on. So we basically used large databases from hospitals, we got a hold of the Medicare data, for example, and we went into hospitals that were not already on an organized system and actually subscribed the data. Went into nursing homes, and by the time we finished, we had pretty much profiled the entire system in terms of its variability from one place to the other, and also began to look at its productivity, questions of whether more was better.
It might be worthwhile, for the benefit of our viewers, to say a few words about the conclusions or the major findings of the paper at the time.
The paper really was not a hypothesis at all, in the sense that we basically were doing an empirical description of the system. And in that, we were able to measure the location of local healthcare markets or service areas. We were able to measure the amount of resources that were used, how many doctors, labor inputs were made, how many personnel associated with hospitals other than physicians, how much money was spent, how many beds were invested in the care of these populations, all on a per capita population basis, which was probably the most unique thing about what we were doing. Instead of looking just at institutional behavior, like occupancy rate or throughput of patients. We actually got down to the question, how much care is actually delivered to these populations? And by the time we went through the resource inputs, we then looked at the utilization rates and found these incredible variations in common surgical procedures such as tonsillectomies. We found that, for example, in Morrisville, Vermont, which was just 6 miles from where I was actually living at the time, the kids were having their tonsils out at a rate, about 65% of them were tonsillectomized by the time they reached age 15. Whereas in my own hometown of Waterbury, the rate was about 20%. So those big, huge variations just didn't make sense in terms of the common assumptions about healthcare. So the conclusions that we came to was that the system behaved much differently than most people were thinking, including ourselves when we set up the idea of regionalization. More fundamental issues such as what is the value of healthcare and what is the best way of practicing healthcare emerged rather than the questions about underservice and how can we make sure that the advantages of the scientific innovations that have gone on through the NIH were available to all people. That was basically the theory behind regional medical programs.
Having established now almost 40 years ago the notion of variability in healthcare delivery, consumption, and quality, as we speak today, do we have a sound understanding or at least an improved understanding as to what might be driving this geographic variability?
I think we do. I mean, I think, we've been pursuing this thing for 40 years, and I think at least here within the Dartmouth circle, we think we have a pretty good understanding of the drivers of practice variation. The first thing that's important to distinguish is whether illness is driving variability. And it turns out there's very few conditions for which we can be quite certain that illness is driving it. For example, hospitalizations for hip fractures are pretty much driven by illness. And I think your clinicians and your audiences will see why. It's because people who break their hip know it. They seek care. It's not hard to diagnose, and all clinicians would agree they should be hospitalized. So therefore, the hospitalization rate is a pretty good indicator of the actual incidence rate, the hip fracture rate. But that's one of the very few things that vary that way. Surgical procedures, admissions for chronic illness, visits to physicians for chronic illness, all show much more variation that can be explained by illness or patient access.
And the absence of that as a sufficient or credible accounting for the variability, are there other hypotheses or reflections on what might be driving this variability?
For what we call unwarranted variation, that's variation that cannot be explained by illness or by patient preferences or by access to care. There seems to be two basic streams of activity that we have identified. One is for procedures and interventions for which there is more than one option. For example, hysterectomy is done for uterine bleeding commonly. There's other ways of treating that condition other than hysterectomy. And the same is true for most of the in fact, for all the common procedures, particularly those that show high variation. There are treatment options. The decision process is driven by very strong ideology and theory. Surgeons don't operate on patients without a pretty good reason for doing it. Now the question is, what's the evidence that the assumptions that are made are true, that we really can predict what's going to happen? But even more important, particularly as we've seen over the last 20 years, is the patient's preferences, that treatments have different outcomes. Treatment options commonly have different outcomes. And even in cases where the outcomes are well known, we see plenty of evidence that patients aren't getting involved actively in the decision process. Let me just mention simple example of breast cancers, early stage breast cancer. Do we treat that with lumpectomy or do we treat it with mastectomy? RCTs, randomized clinical trials, show that the effect of survival is pretty much the same. But all the other outcomes are quite different. And it would be pretty hard to argue that those other outcomes should be decided by the physician rather than the patient. And yet there's strong evidence, particularly in the way we've always conceptualized the role of the doctor-patient relationship, that patients do delegate decision-making to physicians, and generally the preferences of the physician become more important in the decision on surgical procedures than they probably should be. Now, there's this other bit of clinical activity, which epitomized by managing, say, chronically ill patients, where we see a much different set of issues. Instead of having disagreements about the value of the procedure versus alternatives, in the case of chronic illness, what we're mostly seeing is just variation in the intensity with which patients are treated. For example, how frequently a patient with chronic kidney disease is seen by a physician. Is it 6 months, 3 months, six weeks? How often does somebody with congestive heart failure go back for revisits? How often are they hospitalized? How often are they put in intensive care units? And it turns out that this kind of behavior actually, at the clinical level, is pretty subliminal in the sense that there isn't a lot of theory driving that issue. There's not, in fact, there's almost no evidence as well. So in the absence of evidence, and the general assumption that more is better, the capacity of the system tends to drive the frequency of use of medical resources in managing chronic illness. And this turns out to be a really important problem in Medicare, because that's the explanation behind the twofold variation in Medicare spending between places like Los Angeles and Portland, Oregon. Yes. It's nothing to do with surgical procedure rates. It's got all to do with how much care we provide to chronically ill patients, including end-of-life care, but not exclusively end-of-life care.
In 1996, the first edition of the Dartmouth Atlas of Healthcare saw press. One might say an outgrowth of your 1973 science paper and your life's work, in a sense. Could you describe, for the benefit of our viewers, or at least briefly describe the scope, content, and overall universe that the Atlas encompasses?
Right. Well, let me actually start with a little bit of the history of the Atlas. You're right. In fact, it's pretty much the same methods that we originally developed in Vermont, at least in the early editions of the Atlas. The Atlas was actually conceived in the context of the Clinton Health Plan and the efforts at that time to reform healthcare. Right. We were working in some degree as advisors to Hillary and her colleagues, and it was clear that they were trying to set up this competition managed competition. You may remember that, and it was going to happen in regions, geographic regions. And we knew from all the work we'd done that the geographic regions vary enormously in the amount of money being spent, the resources available, and the way healthcare is delivered in those regions. And if one is going to try to set up competition at a region, one has to know what's going on in the region. And that was our goal, was to basically provide an analysis that the instruments that would be first developed under that plan were put in place. Now, of course, when the Clinton Health Plan tanked, here we were with a nice grant, which we, by the way, received from the Robert Wood Johnson to do this. We developed this geographic analysis for the whole country using Medicare data. Remember, the work that we'd done up to that point was pretty much restricted to a few states. So now we had a national database. So what do you do when you have data and no audience? Well, you create an atlas, and that's the way it happened. And that was always part of our premise, that the feedback of information on performance to broad audiences was one of the most important remedies that one could bring about in terms of practice variations. Because if you don't know they're there and you don't pay any attention to them, you're not going to be able to do anything about it. So that was our original premise with the atlas.
We may have taken the liberty of making light of perhaps the birth of the atlas, but I cannot help but believe that since its inception to this day, the atlas almost certainly has influenced health policy making in the United States. I would be very interested in your thoughts on that.
Well, I think that the important, step of the atlas was to make transparent what previously had been hidden, namely very striking differences between local places. It wasn't just that we could show that remotely Vermont was off the mark, but this now was a message that could be brought anywhere in the country. And so initially we saw a lot of interest on the part of the American Hospital Association, who basically was the publisher of the first Dartmouth Atlas.
I didn't know that.
We did. As things moved on, it became clear that there was going to be controversy, there was going to be dissidence, there was going to be debate about what this all meant. And we basically then got the sponsorship to go back to the Robert Wood Johnson Foundation, and we have since then been independently, in quotes, funded to do this. So we haven't depended on any one of the actors in the system. But I wouldn't attribute its influence at all necessarily just to its apparent objectivity, but rather once you get into the trenches and you start trying to figure out what to do about practice variation, you're always led to the fundamental problem that science is poor. Our clinical science has not been nearly as developed as our biomedical science. We really don't understand what we're doing in terms of outcomes in many, many examples. And secondly, we see big differences in spending levels and evidence that if you looked more like the Mayo Clinic, or if you looked more like some of the better organized practice systems, you would spend a lot less money on a per capita basis than is now going on in most parts of the country. So it became clear that there were some of these best practice models that we earlier had not been able to see because we weren't looking so deeply into the problem. Now we could see that group practices tended to be more efficient, not just in terms of their cost per case, per service, but rather in terms of the per capita costs that actually went on in the regions in which they were located. So this became part of the issues. At the same time, we were able to see extraordinary differences in which some hospitals, but one thing I haven't mentioned is that as we went along here, we were able to begin to get hospital-specific as well as region-specific information. So we could show, for example, that within Los Angeles, while Los Angeles was quite costly compared to many other parts of the country, there was a twofold difference among the individual hospitals within Los Angeles in terms of their cost in managing chronically ill patients. Mm-hmm. So we were able to bring this information further down, not just only to the region, but now to the hospitals. And finally, at least in terms of the political impact, I think by being able now to profile major academic medical centers across the country, seeing twofold variation and greater among our leading institutions, that the original comparisons that we'd made between Boston and New Haven, which caused quite a stir, now became the rule rather than the exception. And that brought, again, great evidence towards the need to do something about the scientific basis of medicine.
To what degree, if any, do you think did the Atlas influence the Affordable Care Act or the process that led to its formalization?
Yeah, I think it had a lot to do with with the assumption that, I'll put it this way, we had said, and we wrote a white paper about this, but we'd said this many times, that if you use benchmarks of efficient practice, we can indicate large opportunities for saving money by becoming more efficient.
Yes.
And when the concept came out that we were going to increase entitlement, our argument was that if we keep the system steered the way it is, if we don't increase capacity, our analysis says you basically won't increase spending as much as you think you would, because there's only a certain amount of capacity. It's going to be allocated in a certain way, and that's what's the dynamic now. Is most services show evidence of supply influence, strong influence, either at the individual ideology level of you need this surgical procedure or you need this non-surgical strategy for dealing with surgical conditions, or the chronic disease problem that we've been talking about. We created the condition of possibility, essentially, that you could in fact move aggressively to increase entitlement without accelerating the inflationary rates. Certainly Peter Orszag and that group picked up on this and moved ahead on it. You know, there's another whole side of what we do that it doesn't get focused so much largely because the Atlas has kind of been the focus of policy debate, but much more interesting in many ways is the work we did in medical effectiveness in the days of the prostate studies. Are you familiar with those?
No, but
Yeah.
please.
Yeah, this goes back historically to the steps that were taken after we finished the Vermont study.
Mm-hmm.
We also had the opportunity at that time to begin to look at what was going on in the state of Maine. And at that time, the editor of the Maine Medical Journal, which, by the way, is now defunct, was Dan Hanley, who was a very influential physician in Maine. He was on the U.S. Olympic Committee. He was Bowdoin College physician, and he was the secretary of the Maine Medical Association, but he was also the editor of the Maine Medical Journal. And he published a series of articles showing practice variations in Maine. And he did much more than that. He basically said that it's the responsibility of practicing physicians to look seriously at these problems and to begin to address them. So working with Dan, my colleagues here at Dartmouth and ultimately in Boston set up a strategy for taking feedback reports to physicians to show them what the practice patterns were in their communities and in other communities. And we basically set up a three-step process. We said, will the practice variation information itself lead to reduction in variation? If not, can we go to the literature and figure out what is actually going on and make some judgments about inappropriate care? And if we can't do that, if we draw a blank on that, can we take the studies that would actually clarify what was going on? And it was that three-step process for benign prostatic hyperplasia, BPH, that led to the first, I think, example of medical effectiveness research, but not just research, but rather a consistent effort to try to take the theories that were being exercised by local physicians, subject them to critical appraisal, go on to the data, and interestingly enough, in the case of benign prostatic hyperplasia, that led to the clear identification of the role of the patient in decision-making and the necessity, if we're going to deal with practice variations, of changing the doctor-patient relationship from classic informed consent to informed patient choice, leading to decision aids to the Foundation for Informed Medical Decision Making, with Al Mully and I started in 1989, and that led to a whole stream of activity which ultimately influenced the Obama plan with the concept of shared decision making, which is now becoming more and more established in everybody's thinking. So we were looking here basically at remedies.
Yes.
And the atlas is a positor of problems, but the concept of medical effectiveness research coupled with patient preferences, understanding of the role of patient preferences, and the creation of decision aids, objective decision aids for implementing those in everyday practice represents a remedy which the Obama plan actually has in its agenda the establishment of shared decision making, and in the ACOs now that's one of the requirements.
It's undeniable that we as a nation are going through a difficult patch with respect to a variety of aspects, not least of which healthcare. If we were to liken for a moment the American healthcare system to a patient, somebody such as yourself who has been observing the system for a long time, what is the prognosis of this patient?
The patient being the healthcare system.
The American healthcare system.
Well, it's certainly going to have to figure out how to go from a spurt of growth to a spurt of maturity and stability.
From puberty to adulthood, you're suggesting.
Well, we could use those words. So that everybody understands that the growth curve cannot be sustained. And certainly the great difficulty is whether the adolescent can enter into a new phase in which there is a cooperation and an understanding of the requirements for building systems of care and doing things which physicians were not trained to do, work in teams, and also ultimately limiting capacity, which is yet another dimension of this problem, because then you get into the whole macro system, economic system of what drives novelty, what drives growth in terms of pharmaceutical industry, device industry, all of the now highly organized, capital-intensive organizations that influence our everyday practice. Not to speak just of the hospitals themselves.
Yes. Finally, and more on a personal note, if I may, and I may take you to a time preceding 1973, maybe you could share with our viewers what it was that led you to the area of healthcare in general, to become a physician in particular, and then one who also embraced population health, having obtained a degree in public health and having become in so many ways a leading proponent of the same.
Well, it's hard to answer a question that probably has many different threads coming into it. I know that my undergraduate training was entirely in the social sciences or in humanities, so I was not the classic pre-med. And so I came to medicine with a different viewpoint, or put it this way, different sets of experience. And I had one experience when I was at Hopkins that I might mention, and that is, at that time I was on the nephrology service. I was basically trained as a nephrologist. And we had a patient that died after kidney failure apparently caused by a reaction to a drug that was given to visualize the gallbladder. And I began to look at that and uncovered the fact that there had been some 25 deaths in the Washington-Baltimore area from this drug. And also began to give the drug to cats as an experiment to see how much they could tolerate, and noticing that the cats weren't doing so well and some of them died. And that became sort of an eye-opener to me about the consequences and problems of failure to organize and understand the outcomes of what you're doing. And it also was an interesting example of where there wasn't any process in place that could really deal with this information. The administration at Johns Hopkins took the drug off their market, but that was the limit of their responsibility as they saw it, and these other places continued to use it until eventually the Congress got involved, and this was at the time that the FDA was under, well, it didn't really exist the way it did now. It was about the time it was being formulated.
Mm-hmm.
So this particular example was used as one of the reasons why we needed to do something on that. So learning the relationship between what goes on at the macro system level, the regulatory system, and what we as physicians have to deal with, really got me interested in public policy issues.
Thank you for sharing.
You're welcome.
On this note, sincere thanks to Dr. Wennberg and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Adashi.